All right, welcome everyone to our last August high rounds. I think it's been a little bit of time. Nope, she probably spoke last year and I'm just forgetting, but I think it actually has been some time since we've talked about hepatitis C. And getting some updates from Dr. Promer is going to be very exciting. And of course, low barrier treatment is what we're trying to do in so many domains. So very exciting to have Dr. Kathy Promer, an associate physician in the Department of Medicine at UC San Diego Health. She's board certified in both ID and internal medicine and provides expert primary care for individuals living with HIV at the Owen Clinic. She earned her MD from the University of Toledo and completed her residency and fellowship at UCSD. Her research spans HIV-related metabolic health, Chagas disease diagnostics, and infectious disease epidemiology, including COVID-19 vaccine trials. A fluent Spanish speaker, she balances her clinical and research work with hobbies like dancing, yoga, and outdoor exercise, as well as two very adorable children. And with that, I will turn it over to Kathy. And Kathy, I'll keep an eye on the chat for you.
Okay. Well, thank you, Jill, for augmenting my biography quite a bit. All right.
That was Marvin, and he did a great job.
All right. So here are some disclosures. I had received an honoraria from ViiV for preparation of educational materials, but that's not relevant to this talk because they don't make the main hepatitis treatments. I opted to use drug brand names in this presentation for convenience because the generics are quite a mouthful. So that's why I use that, not a preference for those brands. And then I guess just a little bit of background, it wasn't mentioned in my biography, but most of my hepatitis C experience actually comes from San Isidro. So I just wanted to give a shout out to San Isidro. Okay. So I'll be going through epidemiology, diagnosis, pre-treatment assessment, treatment of initiation, direct acting antivirals, and monitoring during and after treatment in some cases. So I named this talk low barrier treatment because part of it is I want, all the providers on this call to be comfortable, working up hepatitis C, maybe starting treatment, lowering barriers. All right, so a little bit about the epidemiology of hepatitis C. This is a graphic by the WHO in 2022 depicting the prevalence by WHO region. And globally, there are estimated 50 million cases of chronic hepatitis C. And just to put that into perspective, a lot of us, think more often of HIV than hepatitis C, and there are 40 million cases estimated by UNAIDS. And with hepatitis C, why are there so many cases if we have a cure? And part of that is coverage of hepatitis C testing. So globally, it's estimated that 36%, there's a 36% coverage of test diagnosis. So most cases haven't been diagnosed yet, and about 20% receive treatment. And you may think, oh, that's of other regions, but in the region of America, our numbers aren't much better, 44% and 26% respectively. And here's the breakdown of burden by country. And again, it's not a problem of other countries because the US represents 2.4 million in the top 5. And more specific, to focus more on hepatitis C in the United States, these are CDC estimates from 2022. There are 4,800 new cases of acute hepatitis C reported, but it's estimated that there were 67,000 acute infections. There were 93,800 cases of newly reported chronic hepatitis C during 2022, and an estimated 12,700 deaths related to hepatitis C. There are various risk factors that we think of, classically injection drug use, but also intranasal recreational drug use, crack pipe use, men who have sex with men, chemsex, but then also risk exposures like long-term hemodialysis, needle stick, or sharps injury, injection in an unregulated setting, transfusion, clotting factor concentrate, incarceration. Okay, now to move on to diagnosis of hepatitis C. Really, the main diagnostic we think about is the hepatitis C antibody. If it's reactive, you reflex to RNA to determine if the infection's active, and link to care if appropriate. If it's non-reactive, then you can say that there's no hepatitis C infection, with the caveat that if you're concerned for recent exposure, you may want to repeat the testing in the future and/or just go ahead and check the RNA. All right, now for pre-treatment evaluation. Baseline assessment recommended by the American liver disease or guidelines are within 6 months getting LFTs, GFR, and CBC, a quantitative HCV RNA. You don't always have to get a genotype. You can get a genotype if you're considering a non-pan-genotypic regimen, or maybe if you have like a concern for cirrhosis where the genotype might affect your treatment. Hepatitis A total antibody, if they're unvaccinated or they don't have a previous antibody level. Hepatitis B studies, HIV screening, and pregnancy screening if applicable. And along with this, it's recommended to assess for liver fibrosis, to see if there's advanced liver fibrosis or cirrhosis. Of course, the gold standard we think of is a liver biopsy, but it's not without risk, and it's not very low barrier to go through that process. So you can start with a FIB-4 or APRI, which are scores that I'll go through in a little bit using common blood tests that we would otherwise get, FibroSure or ELF, transient elastography, shear wave elastography, or MR elastography. So here's the FIB-4, the fibrosis-4 calculator. It just uses age, AST, platelet count, and ALT. So very easy tests to get, and probably results we would have otherwise had. And so for hepatitis C, you can use a cutoff of 1.45. Below that cutoff, you have a pretty good negative predictive value for advanced fibrosis. The APRI is another calculator, just using AST and platelet count. And it's again another easy score, but it's thought of to be have less negative predictive value and have some more limitations. And I will say with the FIB-4, it's really easy and Epic. You can just write .fib4 and it'll calculate it for you. All right. And then there's the FibroSure, a multi-component blood test. It has to be done fasting. It's not available through UCSD, but it's done through LabCorp. If you're interested in ordering it, I guess you can just do lab miscellaneous and get it drawn at UCSD. It's my understanding if you want a test that's not available at UCSD, you just order lab miscellaneous. And they'll route it if, because because it's not available at UCSD, and it uses all these components. And then there's the ELF score, which uses different components, but another non-invasive blood test to measure fibrosis and scoring it, anywhere from 0 to 4. And this is available at Quest. Again, not available at UCSD, but you can order it as lab miscellaneous. Okay, Now to talk about transient elastography. With this, you generate a shear wave and you use the ultrasound to measure the speed. And then you can use that to compute liver stiffness, and which can then be translated to a fibrosis score. And with the low liver stiffness, a good happy liver, the speed is slower. With a high stiffness, sad liver, as you see, the speed is higher. There's also ultrasound shear wave elastography. You can order this as a radiology test. I think it's under like facility orders. If you just type ultrasound elastography, you should be able to find it that way. But one limitation is we have a FibroScan machine in Owen Clinic, and then the ultrasound would require sending them to radiology and potentially billing issues. And then there's the MR elastography, even more expensive, maybe tolerability issues, if they're, the patient's claustrophobic or particularly large. But it's another test that's available. And there's a passive driver used, and then they generate the wave and then measure the speed, and then estimate fibrosis as with the other elastography options. So that's a lot of tests. Obviously we wouldn't want to do all of those in someone that we're seeing for hepatitis C. So, one question is how do we choose which tests are necessary for the patient in front of us, removing as many barriers as possible. And for, hepatitis C, I'd like this type of algorithm, which is for NASH, where, can you use just like a FIB4 and then proceed with, a L4 FibroSure, FibroScan if necessary, removing any barriers. I couldn't find kind of a set out, algorithm like this for hepatitis C, but there is a lot of research on it. Here's a study kind of estimating like the negative predictive value and AUROC for ELF and FibroSure. Per this study, the negative predictive value is over 90% for both ELF and FibroSure. And it's broken down by NAFLD and hepatitis C, hepatitis B. And here's another study kind of trying to look at, how useful is it to add FibroSure to FIB4? And how useful is it to add transient elastography? And you can, and this is based on a population, I believe the population was in Oregon, although all the authors of the paper seem to be from Boston, but I guess they found some data from Oregon that the prevalence of cirrhosis in hepatitis C patients was about 4%. So that's how they're calculating these negative predictive values. So these numbers, of course, could change depending on prevalence. But as you can see here, the negative predictive values are pretty good. And, this is really the main number we should care about because, if, FIB4, seems negative for advanced fibrosis, how confident do we feel stopping at that? Okay, and so their summary was that FIB4 alone, if you use the cutoff of 1.45, has a negative predictive value of 98.2%. And adding FibroSure doesn't really seem to add to that, so that it's not something that they recommended in this paper. But adding transient elastography was reasonable if their FIB4 was higher. But again, performing transient elastography for all was not recommended. So it was suggested that, you should reserve the transient elastography for those higher FIB4 scores. All right, so now staging of cirrhosis. Okay, so if you do find, with these non-invasive markers that you're concerned for advanced fibrosis, cirrhosis, it's important to stage it because you can use the simple treatment algorithms if it's well-compensated cirrhosis. So you use the CTP calculator with these variables: encephalopathy, ascites, bilirubin, albumin, INR. So again, with those minimal, initial blood tests that we commonly use, plus INR, and then assessing for ascites and encephalopathy, you can, it's pretty easy to come up with this score. All right, and so, and in this, and this just marks that, if you do assess that they do have cirrhosis, it's important to screen for HCC. And so, and the idea is, even if their non-invasive measures improve afterwards, you still continue with the cirrhosis screening, generally ultrasound every 6 months. All right, so timing of treatment initiation. The basic message is the sooner the better. These are from the guidelines. Treatment is recommended for all patients with acute or chronic hepatitis C. So it used to be not too long ago that if they had acute hepatitis C, you might wait to see if they cleared it on their own, which happens not uncommonly, but really the current guidelines are, it being acute doesn't mean that you should wait. Exceptions are those with a short life expectancy. And of course, if they have a contraindication, like they're currently pregnant. All right, so benefits of treatment. There's a decrease in liver inflammation and reduction in fibrosis progression, 70% reduction in the risk of hepatocellular carcinoma, 90% reduction in the risk of liver-related mortality and liver transplantation, reduced symptoms and mortality from extrahepatic manifestations, and then reduced transmission. Of course, treatment is prevention, as we think of for hepatitis C. All right, so who's eligible for the simplified treatment algorithm that I'll go through in a little bit? Doesn't matter on genotype. They have not received any hepatitis C treatment, more specifically DAA treatment. They don't have cirrhosis, or if they do have cirrhosis, it's well compensated with a CTP score. And they summarize kind of the non-invasive measures that you can use. And some exclusions are previous DEA treatment, of course, their hepatitis B surface antigen is positive, high CTP score, and current pregnancy, current hepatocellular carcinoma, or prior liver transplantation. All right. So here, here in the guidelines is a good example of low barrier treatment. So you start with the point of care HCV RNA pregnancy test HIV screen. If the point of care HCV is positive, you assess for prior treatment, current hepatitis B infection, hepatocellular carcinoma, and clinical evidence of cirrhosis. If you have a green light with that, you do medication reconciliation, draw labs, discuss the risks of hepatitis B co-infection because you haven't assessed for it at that point. And that, if the result is positive, they'll be contacted to discuss treatment. And at that visit, you go ahead and start treatment, which with the DAA drugs that I'll discuss in a little bit. So kind of like with a rapid start with HIV, this is kind of an algorithm that you can potentially use to rapid start hepatitis C. Okay, and so, why do I discuss, only using, more advanced staging for fibrosis if necessary? There is a significant impact on delay in treatment because especially, if the modality is not available right to the provider, like we have a fibroscanner in clinic, it can lead to a significant delay. And with this study that, it's in London, published in London, they found that FibroScan led to FibroScan and FibroSure, even the blood test, led to over a 6-month delay. And liver ultrasound also led to a delay, but, the average seemed to be less than 6 months. And so this does have an impact in, the amount of people that end up starting therapy, completing therapy, and getting cured. And of course, it's always more satisfying if we can, address it more quickly, especially if there's not a reason to delay it. Although the numbers presented here aren't super dramatic, but we do see a significant impact on these clinical outcomes. Okay. All right. So hepatitis C treatment initiation during hospitalization, which I think has, been discussed at UCSD and has been done in very rare cases. So, obviously this is a way to lower a barrier if a patient's, admitted for another reason and, through the program formerly known as Focus, they get screened in the ED, found to be positive, or, they've been positive before, but they just never been linked to outpatient care. The question is, can we just go ahead and start it in the hospital, especially if they'll be here for a while? So this study published in OFID during this year found that inpatient versus traditional outpatient referral initiations, it was 86 versus 46%. There was improved rates of treatment completion and improved rates of cure, although there was some variability. It was a summary of literature. So
Just make a comment about that at UCSD. Kathy, the just treating in the hospital. I mean, one of the big barriers is that it's not easy to get treatment in the hospital. I saw Shannon is on, who maybe can speak to this. It is approved through P&T, but they really, because of the cost, it is not offered inpatient unless, like what you say, someone's going to be here a long time, or if they had started treatment already and they'd be continuing it. We just had someone who was interested in getting started and was going to be discharged in a week or so, and that wasn't going to be considered, which I think is a big issue, and one that maybe could be returned to at some point. But I don't know if Shannon, you have anything you want to share about what you know of in terms of I don't know why it's so expensive. I don't totally understand it.
I will,
No,
I have
and
discussed it here. If I may just say, Epclusa and Vosevi and Mavorite, they all come in set amounts when the pharmacy gets it. Epclusa is in a 28-day supply as well as Mavorite. And so there's something about we cannot mix with a single bottle or a single box. We cannot mix inpatient and outpatient. So if you're not completing like exactly 28 days or, twice that or 3 times that in the hospital, you're having to waste drugs. But I don't know, maybe Shannon, I don't know why you can't like mix inpatient and outpatient billing, like say, we want 7 tablets billed to the inpatient stay and then the rest of the bottle to outpatient. If they only complete part of a bottle inpatient, it gets reserved. And then they get a full bottle when they get discharged. So
it just seems like there's similar situations where we decide to or not to, and it just seems like it's a barrier, right? I don't know if anyone can speak to this, and maybe we're wasting our time right now, and Kathy has lots to talk about.
It's okay.
It just seems like a great place to treat people and get people started on treatment. And it's, to me, a real shame that there are barriers related to, medication procurement and insurance that is the barrier here. Maybe Shannon's doing something right now.
Yeah, I mean, you make a lot of great points. It's the system we live in, right? And it occurs in all disease states that are expensive to treat. Unfortunately, the inpatient budget, like you mentioned, you buy the full bottle. It obviously would stay in stock if you don't finish it and use it for the next patient, but all of that kind of goes under the umbrella of the hospital kind of footing the bill for that, as opposed to on the outpatient side, you can bill insurance directly and get reimbursed for the cost of the product. So the hospital ends up kind of eating more of the cost. So P&T, I think, has just asked us to be mindful of that because the costs of all drugs are going up and up and up and up, and they've asked us to keep the pharmacy budget the same for years and years and years, despite the increasing cost of all of these brand name products. I wasn't there for the P&T discussion, so Lucas may have more to add, but it's kind of the same approach for everything. You know, at least we do have it if we deem it clinically, you know, urgent. But I think the request is to just kind of be mindful of overall cost because
Yeah.
it is very expensive.
Yeah, it is very expensive. I mean, I can add, and I don't know, I'm not saying that this is the right opinion, but I think the argument is in most scenarios, starting Hep C treatment isn't urgent. And the argument would be, well, they have to follow up outpatient anyways with a specialist, or even if you start them. So why start them for a week in the hospital versus, and when they're going to have to follow up with a clinic outpatient to continue treatment, whereas you could just start them when they go follow up outpatient, right? And then not have that cost billed to the hospital stay for the short-term amount of medication. So
Well, that would
I
be
get,
an interesting study, right? Starting in hospital versus, you know, for someone who's going to be imminently discharged, and are
right.
your completion rates better?
Yeah. I mean, some of this discussion originated back when it was a lot harder to get these meds covered by insurance. And so there was always the concern that if you started inpatient, could they continue it outpatient? Was there a clinic they could go to? You know, can they continue to get their hepatitis C care when they're discharged? You know, some of these things have changed a bit, obviously, over time. So, you know, it's worth
Right.
revisiting. But again, I
That's
think
what
the
I
argument
wonder.
would be,
It seems like it's a lot more straightforward
and
now.
it's like I mean, maybe like you said, a study, but you know, the point is if they're not going to follow up in a week from discharge to continue their treatment, you know, what would be different than them just starting when they follow up in a week after discharge is the argument, right? That, you know, from a clinical perspective, starting a week in the hospital or starting a week after discharge doesn't make a difference. So, but we don't know, does that change completion rates? Does that change follow-up? We don't really know.
But my question is, you know, do they need to follow up, you know, if they started inpatient, you know, and if you give them like the full treatment course,
Right.
you know, you know,
that's a legit point as well. Yeah. You know, right now insurances aren't covering full treatment courses. We've had a case or two of Medi-Cal paying for the full amounts, but that seems to have been walked back a little bit by Medi-Cal. So it's hard to get the full treatment course, you know, dispensed in one dispense. But yeah, I know these are all legit questions because things have changed over time with hepatitis C treatment. So
We'll let you go on though, Kathy. So thank you. Oh, I guess, right, that was.
oh yeah. So yeah, so
enough.
this, yeah, yeah, I mean, I guess my next strategy was going to be to reach out to these authors or whatever, see how they, you know, how they think it should be feasible. Because my, you know, my concern beyond like inpatient billing was like waste of drug, because, you know, these are expensive drugs too. So, you know,
But it sounds like that's not the case from what Shannon's saying.
okay.
You could use the medications on the next person.
Yeah. But then when they get discharged, they get a full bottle or a full box. So they're getting extra
Right.
drug. And then I will note, you know, I know this isn't the biggest priority, but like, you know, I had one, you know, maybe it doesn't happen that often. I had one patient that I started Mavorite on. He ended up going into the hospital. They couldn't, you know, for neurosyphilis. They couldn't figure, you know, they couldn't get him OPAT. So he stayed for two weeks. This is before I think the guidelines said that maybe 10 days is enough. And they used the inpatient Mavorite and didn't allow him to take the Mavorite he brought with him. You know, and I know they have good reasons for that, but there was also like 2 weeks of wasted drug in that case. So, but yeah. All right. Yeah. If cost is a big, concern, you know, maybe cases like that, you can consider changing the rules. I know that's not easy. But okay. So this paper, you know, published in OFID this year, they recommend optimizing HCV identifications. I think, you know, Dr. Blumenthal's work has really helped with that because, you know, we recommend opt-out screening for people presenting to the ED. Initiate DEA therapy during inpatient admission, which is not something we can realistically do right now. I advocate for widespread availability for affordable pan-genotypic DEA therapy. I think easier said than done in this political climate. Collaborate with multidisciplinary teams to address specific social and structural determinants of health, to reduce barriers to treatment adherence. And I will say, there's one strategy I didn't discuss in this, which is kind of street medicine, which, is not something I've been involved with, but that's also another strategy beyond this ED-based screening and connection to care. Adopt low barrier and simple approaches such as telehealth services, minimal monitoring to coordinate follow-up so that, as Dr. Wilkins said, studies these days suggest it's probably best for the patient if you just give them all their meds in a bag and let them go on their way. So kind of that low barrier, not making them come to the clinic if it's hard. Okay, and I already mentioned this. Okay, so now let's talk about a little bit more about treatment. Simplified treatment, your main options are Mavorite and Epclusa. I'll go through the generic names in a little bit. Mavorite's 8 weeks, 3 pills a day with food for 8 weeks. Epclusa is 1 pill a day with or without food for 12 weeks. So as the Epclusa rep pointed out, it's technically less pills, but but the fact that it's with food and the amount of pills per day may, a lot of patients express a preference. So I present it as that. If really, they have either option. If they have compensated cirrhosis, in most cases you can use either, but there's a caveat for specifically genotype 3 without Y93H. So this is maybe a case where you might check a genotype 3 if they're really interested in Epclusa. Exclusions are, as I talked about, previous treatment, current pregnancy, hepatitis B, decompensated cirrhosis, liver transplant, HCC, and ESRD in combination with cirrhosis. So Epclusa, the generic name is sofosbuvir velpatasvir. Sofosbuvir is a nucleotide analog of the NS5B polymerase inhibitor. Velpatasvir of the NS5A is an NS5A inhibitor. As I said, it's 1 pill daily for 12 weeks. Mavorite is glecaprevir. Again, maybe I just don't say these well. Bimperzesavir, brand name Mavorite. It's a NS3/4A protease inhibitor and NS5A inhibitor. As I said, 3 pills oral daily with food for 8 weeks. So, if a patient's on other medications, I ask how they take it with or without food, because, if they can just take it at the same time as their other medications, that I think that sets them up for better success to be adherent, so they don't develop like a new habit. Okay, and so this is just a little graphic that I liked, kind of summarizing where the drugs act at. They both act at NS5A, and the difference is the NS3/4A for Mavorite and NS5B for Epclusa. Okay, they're both highly efficacious, over, around high 90%. And this includes subjects lost to follow-up and all genotypes. They're both very well tolerated. The most common side effects for both are headache and fatigue at comparable frequencies. The vast majority of patients were able to complete even if they developed an AE because they were mild in severity. And one thing you do have to consider is drug interactions. This is not a comprehensive list, but of course it's important to perform a full reconciliation of prescription and over-the-counter medications and supplements. One thing you want to ask about is antacids. The interactions are more significant for Epclusa and Vosevi, rifampin and erfabutin. You just can't use them with DEAs. some antiviral medications for HIV, anticoagulants, anticonvulsants, antiarrhythmics, and St. John's wort. But really, to be safest, you can just go ahead and plug in all their medications along with the treatments you're considering into the Liverpool interaction checker. All right. And some additional counseling, of course, importance of treatment adherence and communication with the clinic. Avoid or minimize additional stresses to the liver, such as, of course, alcohol or maybe other medications that may stress the liver. That mild headache and fatigue are common. And to reduce transmission risk by avoiding sharing needles, toothbrushes, razors, using condoms. Monitor for hypoglycemia if on diabetes treatment, because diabetes can be worsened with active hepatitis C infection. So maybe they won't need as much diabetic treatment if they're getting treatment. And monitor INR if on warfarin. So monitoring during and after treatment. Telehealth is a nice option if you don't otherwise need to see them in clinic and they're reachable by phone. And you can talk about adherence, if they've had any adverse effects, drug interactions, and, make sure they haven't started any new medications, symptoms of liver injury. And then really the most important time point to repeat those labs is 12 weeks after treatment completion. Just the HCV RNA and LFTs. Very often, I've seen it repeated, during treatment, at the end of treatment, and that can be considered, but really the most important number is 12 weeks after treatment completion. All right. Some challenging and complicated situations. And again, these are all in the guidelines. If you have treatment interruptions, there's really clear recommendations of what to do. If there's a brief treatment interruption, less than 7 days or more than 8 days, if you can just go ahead and restart their previous treatment or, stop and then restart it, consider restarting it later. And of course, treatment interruptions are more important in the first 28 days because it is possible, even if they haven't completed the full treatment, that they may still clear. But of course, that's another reason why I don't like to check, RNA too early, especially like during treatment, because I think that might be interpreted as, oh, okay, I don't have to complete treatment. But yeah. All right. Now to go on to the treatment experience, it's most important if their DAA treatment experience. If their treatment was prior to DAA therapy, then it's less significant. The concern is that it may result in mutations of NS5A, and then as I talked about, both drugs act at that. So if you've had a sofosbuvir-based or Zepatier failure, you treat with Vosevi for 12 weeks, add ribavirin if genotype 3 and compensated cirrhosis. For Mavorite failure, Vosevi for 12 weeks plus ribavirin if compensated cirrhosis. And the alternative regimen you see there, and then there's even a case of Vosevi failure. So, I would expect that person to have had multiple courses of DAAs, adding ribavirin to Vosevi, and then an alternate kind of Mavorite plus sofosbuvir plus ribavirin. And then let me see here. Okay. And then just skip ahead. This is why you add Mavorite to sofosbuvir, because it kind of adds up to Vosevi. So you would only do that, I think, if you can't get Vosevi, but you can get Mavorite and sofosbuvir. Okay. And this is kind of the picture form of what I said there, that, Vosevi is essentially, simplifying it, Mavorite plus Epclusa or Mavorite plus sofosbuvir. So it's a 3-drug acting at all those, with all inhibitors of all those that I mentioned. And it's kind of like Epclusa, it's 1 pill oral daily, but with food for 12 weeks. Okay. And pharmacists, if you have corrections, please chime in. Okay. And then, so what do we do with HIV, HCV co-infection? Keep in mind that there's increased risk for fibrosis progression compared to mono-infected. So I think, when we were, more tight-fisted with our hepatitis C treatment, HIV was kind of a justification to go ahead and proceed with treatment, but that, that's not really a factor now because you don't need HIV co-infection to qualify for treatment. HIV treatment should not be interrupted during hepatitis C treatment. Rather, if you have, precluding drug interactions, you should adjust the ART. And in people living with HIV, you should offer at least yearly screening for hepatitis C. And I would probably say for patients in PrEP care too. Okay. Now for hepatitis B, hepatitis C co-infection. The guidelines have, some direction, determine if, they would otherwise qualify for hepatitis B treatment, based on the hepatitis B guidelines. And you could, discuss the benefits and the risks of going ahead and starting hepatitis B treatment, or, careful monitoring. Okay, so basically just to also address the hepatitis B. Now, so now I'm going to go through a case based on a patient that I saw that I was particularly proud of the low barrier, but it was with my team that I was able to do this. So at appointment 1, patient presents for HIV PrEP. He is uninsured, MSN, no recreational drug use presently or in the past. His point of care HIV screen done in clinic is negative, so he starts Apretude the same day. Routine labs, which resulted after his appointment, showed ALT 84, AST 48, and hepatitis C antibody positive. Unfortunately, our lab is supposed to reflex to RNA, but they weren't able to in this case, so he had to come back and get an RNA, which resulted as 3.5 million, which wasn't surprising with his AST, ALT, and his FIB-4 score was 0.6. So Mavorite was prescribed. So he came for appointment 2 1 month later. I did a fibroscan because we have it in clinic, but it would have been reasonable to skip that, and his fibroscan was very low, as we would have predicted. His Mavorite, he picked up his Mavorite from downstairs. Actually, Alan, our PrEP navigator, picked it up for him and brought it upstairs and handed it to him in the appointment. And he got Apretude number 2. At appointment number 3, he is finishing up Mavorite. He got some food poisoning, so ended up not starting it right away. He wanted to wait till that was resolved before starting a new medication. So a few days later, he started it. So, at appointment 3, 8 weeks later, he was still finishing up his Mavorite. But, once he had started it, he was adherent every day, and he got his Apretude number 3. And we're not at SVR 12 yet, but I would predict that he will have cured his infection. So, so some learning points: rapid start is feasible even with psychosocial limitations. This patient came to us without insurance, and not a lot of additional funding resources. PrEP app covers HCV screening and treatment. Our pharmacy fills DAAs. There might be some there might be some exceptions with certain insurance, but in general, they fill DAAs. And if their FIB-4 score is low, it's reasonable to forego fibroscan. Like if he wasn't able to come, we only have fibroscan on Thursday and Friday, or, for whatever reason, if we weren't able to do the fibroscan with his low FIB-4, I could have just skipped it. And then I just wanted to point out, I think Alan is behind, I mentioned his name earlier. I just wanted to give him a plug because I think he personally advocated for HCV screening and treatment to be covered by PrEP app. So that's a big deal. So I'm very proud of him. That I don't know that MOS Pharmacy always fill DAAs. I added the full treatment course. There have been cases where they've been able to fill the full treatment course, but I just started someone on Epclusa yesterday and they only filled 28 days, which I was a little disappointed about because he lives kind of far away. But I guess it's always good to try. But yeah. Okay. So in summary, 50 million people are living with hepatitis C infection worldwide. DAAs are widely available, well tolerated, and effective. Lowering barriers to screening and treatment help address the remaining psychosocial challenges. Okay. And I think we're ending a little early. These are my main resources. If I didn't put the source on the slide, it's probably because it came from one of these, the hepatitis C guidelines. You can just Google HCV guidelines and find it. Drug interaction checker. There's a free treatment, or sorry, a free learning, web learning through UW, and then reviewing the package inserts. Okay. All right. So let me see if I can exit the presentation.
Don't yet. Can you do the slide of Alan? I want to screenshot it in case he is.
Oh, okay, let me do that.
Yeah.
I think this was on his LinkedIn or something. So I don't,
And
I
he's
didn't
not
ask
on
him if
his-
that's
he's
a,
not
I
on-
didn't ask his permission to use the photo, so I'm sorry.
I just want to screenshot this. Okay. All right. And then I just this was so great. Wonderful summary. Yeah, and Lucas just verified what you said, that he was personally responsible for the DEAs being added to PrEP app for California. So really amazing. Oh, and he's smiling. I think he's off, but he's he feels very good.
He's sitting right next to me, Jill.
Oh, okay, good. I thought he was off for some reason. Can you go back 2 slides with the case? I just wanted to point out right there, the Hep C antibody being positive, and you said it unfortunately didn't reflex. I don't know how long ago, Kathy, was this? Was this before? And this
Like
is,
a month or two ago. I mean, like a
Oh.
few months ago.
so that's very
They
strange.
said the specimen was not sufficient or something.
Okay,
Like, didn't have
got
enough. Yeah, yeah.
So I just wanted to make sure everyone knew, you now cannot order a Hep C antibody without the reflex. And I bring this up to Katie Metters every single time. Somehow it's still on my preference list, and it's what my screen defaults to, but then you can't order it. So you can only order the Hep C V with reflex. And it sounds like this was just not a large enough specimen, but I just wanted to remind everyone that that should avoid problems like this, which used to be a big issue of having to repeat the RNA. Kathy, I was hoping, you mentioned pregnant people. Can you talk at all about why treatment's not offered during pregnancy, and anything about the risk of transmission during pregnancy?
Well, I didn't go into the details about the risk of transmission because the safety is not well studied in pregnancy, but I think there have been cases where it's been started in pregnancy and there haven't been issues, but that's the main reason to wait. But yeah, I haven't been personally involved with that. But yeah, obviously like the fetus would then have to be screened afterwards. But I believe it's they're safe. I meant to add this to the slide, sorry, safe with breastfeeding. So yeah, I would double check last time
And
about that.
Darcy, all the way from WashU, just
Oh
said,
my goodness.
yes, she tries to join when she can. Welcome, Darcy. She says that they treat a lot of pregnant folks at WashU. So this probably is a bit of an area of some controversy. I was just curious. We just had a former focus, EDSP now, referral, who is pregnant, and we were basically said that, or basically told to wait after pregnancy. And I think anything that we do where we wait for patients, like what's being discussed in the chat, when we used to tell people, oh, well, you can't get treated for Hep C until your viral load is suppressed. You can't get treatment if you're using drugs. Anytime we push it off for people, it becomes lower priority. And so I'm not sure if people are aware of ongoing studies where they're looking at treatment in pregnancy. I would imagine that is happening. I don't know if anyone on the call is aware of that. I don't know if that's a Lucas question.
There have
Yeah.
been small studies and of treating during pregnancy.
And those have showed that
Positive outcomes, yes.
Safe. So
Yeah, but they're very, very small numbers.
okay.
And I don't know, I mean, recently being pregnant and then having to take care of a newborn, I feel like I would have been better at taking a medication while pregnant too. So
Right. I mean, that's what it would seem like to me. And then you have to deal with, right, testing of the, I'm assuming, actually, I don't know this. Does the baby get tested? Like
I
what is
believe so. I don't know the exact recommendations. But yeah, that's definitely something to look into. It's not a hurdle I've tried to look at. It obviously
Darcy,
in
let's
coordination
talk.
with OB too, because
Right.
I worry that, if we don't have full buy-in with the full OB department, they might be giving the patient different messages about the safety, or you know what I mean? So yeah, it would
I'll
definitely
just
have to be in coordination with OB.
I can say, and I'm not part of the group that does it, but there's 3 people who are basically on the Hep C service, quote unquote, each week. And they'll go to patients in the hospital, they'll bring meds to beds to get people treated. And then for people who are pregnant, they'll go with them to their OB appointment to monitor and manage their treatment so they don't have to make an extra ID treatment. They've treated in the past 3.5 years 900 people for hepatitis C, and they do it through shared decision making. And they've reported, and they'll report on like their observational data, that many individuals are like, I would rather receive treatment while I'm pregnant versus trying to take treatment postpartum when you're trying to keep an infant alive. So that it's been largely acceptable
The
for the
900 pregnant people were treated?
900 people total.
Oh,
Not all of them were pregnant. No.
oh, okay.
Yeah.
Do you know what number are pregnant?
I don't know how many people pregnant. I think it's less than 100. Madeline McCrary reported on the numbers last year at ID Week. I don't know if she's giving an update this year on it, but I could get those numbers.
Sorry, I didn't mean to make us talk only about pregnancy. It just came up with an EDSP positive diagnosis, someone who's 9 or 10 weeks pregnant, and there's absolutely no follow-up scheduled for her anywhere. So that became a whole point of discussion. And again, I think, if there was consideration of starting treatment for hepatitis C, maybe then she has an appointment scheduled for her as opposed to trying to deal with this all after the fact. So sorry, to people, I know there were a lot of comments made, and I was trying to see. Yeah, I think Nettie, I mean, I think we're all sort of saying the same thing, and it does sound like there need to be some shifts about what happened and what happens in hospital spaces. And it sounds like in certain hospital settings, WashU, they have a very different approach than what we're doing. And I'll just read what Nettie wrote for those who couldn't see it. Some patients have been told in the past they have Hep C, but they don't need treatment and have internalized that message. So there's a big role getting the patient to understand that what they were told in the past isn't true, and building some urgency with that. And I think if you have, and then I'm just going to add my 2 cents, which is I think once you get that started, you want to move on it and not say, well, let's wait on that. So a lot of places where patients may learn about a new diagnosis or a diagnosis that maybe they had that they were told in the past they didn't need treatment for is in the hospital and in the emergency room. And so maybe there should be some new discussion around this now that treatment is a little bit easier to obtain.
Well, I'd be interested to know how WashU is doing it, so maybe I can connect with Darcy offline and if they're billing outpatient and somehow giving, I don't know, yeah.
I think these are great things. Let's maybe you two can connect and then bring the pharmacists in, because I think this is really important. Just to add one other thing, I will present on our EDSP data at some point, but one of the things that the CDPH is encouraging is treatment starts from the emergency room. And you follow an algorithm which looks similar to the algorithm that Kathy posted. It's pretty straightforward. I don't think that's happening in many emergency rooms. I think, again, the barriers include the insurance issue and will someone follow up? And I think we're making the point, and if you could get someone 2 months of Hep C treatment and somehow get insurance to cover it, that would be really easy, and that should do the trick. Of course, we do know that people who, are unhoused may lose the bottles. And there's all sorts of aspects to this that I think we consider for a lot of things that we do. And if the argument is that the medications are so expensive, we can't do that. I mean, I think we have similar arguments for other medications as well. So, yeah,
I would like to make a little
Yeah.
bit of a clarification. This is Shannon. So it's interesting to hear that that's how you guys practice at WashU, Darcy. So for inpatient billing, trying to simplify a very complicated thing quickly is a little bit tough for me, so bear with me. But in general, most hospitalization reimbursement is a lump sum of money based on the particular disease states that are the main diagnoses of the hospitalization, like the primary top 3 to 5 problems, I believe, that are listed for the hospitalization. We get generally a lump sum of money from the insurance to pay for all of the things, including medications, diagnostics, labs, all the things. So that's where then when the purchase price of medications comes into play, the hospital has a set amount of money to kind of make it all happen. And so once the cost of these things get too high, the hospital is essentially losing money on those on the case, is how it's been explained to me. So that's why inpatient purchase price of drugs is so important, as opposed to outpatient, we bill the insurance individually for each drug that's filled. My understanding is because we are billing the insurance is being billed for the inpatient medications as part of that lump sum, we're not allowed to have the patient bring in their own supply of meds. That would be a wonderful workaround for any high cost medication, right? Then the hospital wouldn't have to pay for it. But that's essentially fraudulent, right? That's kind of double billing the insurance because we're billing for the hospitalization and the insurance has already been billed for the outpatient cost. So that's why we have a formulary. That's why we have to kind of decide what we're going to bring in for the patient. And that's why there's the rules around patients really are not allowed to use their own supply of medications. And if they insist that they have to, then we have to do all kinds of documentation around that to kind of cover ourselves. So just to provide a little bit of context, I know there's a lot of nuance and it's a frustrating system. I didn't create the rules, but that's kind of how some of these things end up in place that differ from outpatient ability to bring in drugs, to the point where even if someone needs like a immune therapy for an autoimmune condition, if they got discharged within a couple of days of us getting in the hospital, then the question comes up, why did we spend that money in the hospital when we could have waited 2 days for them to go to the infusion center where they can get reimbursed? So it comes up in all of the kind of high cost diseases to take care of when they're
I mean, we seem
inpatient.
to do it for cancer all the time. So anyway,
Sure, yeah,
answer-
and that's where, it's ultimately P&T has to try to make these decisions to keep
Right.
the hospital drug budget afloat. Yeah, it's not.
The answer
it's
is for the
tough.
drug companies to lower the price of Hep C treatment.
course.
Yeah, exactly.
course.
Like, yeah, it's the
Of
system.
course. I
It's
think we
just
have
it's a
some-
frustrating system for
I
sure.
think we
But
have
yeah,
some people on the call that maybe can take this back. Nettie, what's your question? Maybe Kathy or I can answer. I'm not sure.
I'll try to keep it quick. Sorry. Great talk, Kathy. Thanks so much. Great to see you and really appreciate it. We're, in the world of trying to lower the barrier to care for Hep C treatment. When I think about some of these same day regimens, it's kind of similar to HIV where it's like, yes, we want to do everything all at once all the time, but sometimes it's a little much for the patient. So I was just curious, there might be maybe a separate email conversation, just how people are finding their patients. If I have someone come in and I'm doing a rapid diagnosis of their Hep C, and then we're trying to treat their SUD, and then we're trying to do da-da-da, and then we're like, okay, now the rapid test came back, and now we're going to start your Hep C treatment, but we also want to counsel you about it so you feel confident in what you're doing. Like, it starts to become a lot. And I'm very pro low barrier care, but I also sometimes feel like we try to shove a lot into like sort of a breathless conversation. And so I'm curious, we'll see as we start to roll these things out. It may be that the same day diagnosis, counseling, and offering is the most important part. And, doing a phone visit the next day to make sure they understand their meds before you start them or whatever. So I just want to open that part of the conversation because I do think that sometimes for the patient, it's pretty overwhelming to both get the diagnosis, get the treatment, have the explanation, and do the other thing they came in for, which is often something else very complicated.
I fully agree. And actually, you're inspiring me to email Kathy Jacobson, who some of us used to work with through the CCTG projects, who is now the I think she's the director of all things ID at the CDPH. I wonder if she could come and talk to us because she's a huge proponent of same-day starts for both, for syphilis treatment, for Hep C treatment, for HIV treatment. And I wonder if it'd be useful to, dialogue with her, since a lot of the CDPH recommendations come from, her experience. So I'll tell you, we don't do it in our EDs. I think the only time we're really considering it is if someone, keeps coming back and we have all the information there. I agree with you. A same-day start seems like quite a lot, just with all the logistics, and it would take hours of time, and coordination. So I just started an email to her, and hopefully we can have her talk it rounds. And I realize we're over time. Kathy, this was so great. I think having such a nice summary of Hep C treatment and the fact that it really is simple now in a lot of ways. What's making it more complicated is our insurance companies. That's the take home for me. No, I'm just kidding. But thank you so much. And it sounds like there's some discussions to happen after this talk, so I hope they will be fruitful. Thanks, everyone. Have a nice long weekend, Labor Day, and celebrate however you can. Okay, bye-bye.
Oh, and thanks. I just
Oh.
want to make a plug there's a song called La Bilirubina, and I encourage everyone to listen to it. I was going to make it if I rushed through the talk too much, but it's not scientifically accurate, but it's fun to listen to. The bilirubin.
We already had a copyright strike, so we have to.
Yeah. So I'm not going to play. Yeah. I was going to say cut off that part of the talk if I play it.
But yeah. Nice talk. Thank you.
Thank you.